CT of the brain. I need to be able to check your hormone levels. I need to be checking your thyroid function. He may not be crazy in his description of what you, or be crazy in his explanation to you as to why he's doing it, but sometimes you asking the question, doctor, why, it can sometimes produce a very relevant answer to you. As we continue our discussion on common gynecological problems, we will continue discussing abnormal vaginal discharges and some common causes of pelvic pain. These discussions are not meant to be exhaustive. They're meant to highlight some of the common processes that women present to the physician with, and to give you that feeling of being an expert on your own self as you describe things that are happening to you, and not trying to do it in an apologetic way as if you're not aware of what your body is. You are probably the person who is the expert in describing your feelings, describing the type of discharge, describing how the periods are being affected, describing what the impact it has on you during different times of the month, during different sexual activities, how it affects you. So when you present yourself to your physician, you're armed with the facts and knowing fully well they are not abnormal the way you're describing it. It's exactly the way the physician learned medicine, and it's the way that somebody who is probably expected to be a little bit more learned in gynecology will probably be describing it. We describe first of all the common conditions we see, but we'll look at some of the common vaginal discharge. Sometimes one of the most common discharge is a yeast infection that occurs within the vagina. Sometimes it presents with a white, thick, cheesy discharge that appears around the vulva itself, associated with diffuse pruritus around the area. Because of the pruritus and the cheesy white discharge, sometimes we introduce a secondary bacterial infection, and this results in it becoming from a fungal infection to a bacterial infection. In a case of the person who presents with bacterial vaginitis or bacterial vaginosis, they present with a white, milky discharge that comes from the area itself, not associated with so much pruritus, but associated with a fishy odor that comes out of the vaginal area. But here again, you're describing to your physician. It doesn't have to be a classic textbook description. It has to be what you are experiencing, and sometimes describing it, what is the color changes that takes place on your underwear, sometimes gives away that. So describing discharges, you describe when it started, what it looks like, the area it's being affected. Is it associated with an odor? Is it associated with itching? What is the color it remains on your underwear? Have you had it before? Has your husband or sexual partner been diagnosed with it before? How does it affect your periods? Does it recur when your periods are coming? Has it ever been treated? And if so, what it was treated about? So these are the questions when your physician asks you. You should be armed with them, because this is the information that he or she is expecting from you. We talk about trichomona vaginalis, or trichomona vaginitis, in which is a very it's caused by a protozoal infection that causes a moth-eaten appearance of the cervix itself when you examine it, trying to do a pap smear. It is a protozoal infection that needs to be treated because it is a sexually transmitted disease, and basically not treating it can result in infertility as well. But more important, it's associated with a foul-smelling discharge that is extremely bothersome to the woman. And obviously, knowing that you have it, you should have your partner treated as well. In addition to that, chlamydia and gonorrhea, because of the simple fact that, say, gonorrhea can cause this purulent discharge in the female, or can remain a subclinical infection, can remain non-diagnostic because the woman does not have any symptoms. In the case of the man, you have this very, very painful discharge, and he presents to his physician for the penicillin shot, because that's what helps it tremendously. But the woman is not even aware that she has the disease process and keeps reinfecting herself. But it can result in infertility, because what happens, that subclinical infection causes cervicitis, an inflammation of the cervix, but that inflammation then spreads up to the endometrial cavity and causes an endometritis, and then it ends up into the fallopian tube, causing blockage within the fallopian tube, so that woman now becomes infertile because the egg cannot traverse the fallopian tube. In addition to that, you form the formation of adhesions, which are these fibrous bands that form within, especially when the purulent discharge, and causes infertility. But it also causes chronic pelvic pain as the woman gets older. During intercourse, any activity produces a tremendous amount of pain. We also know that some of the common gynecological causes, away and apart from infections, are when you have an enlargement of the ovary in terms of a cyst within the ovary, a very common condition. That fluid-filled cyst within the ovary itself can be as a result of a fallopian, the maturation of a ovarian follicle that now is left with a sac that's filled with fluid. But that sac can sometimes become extremely large and presents with a tremendous amount of pain. Sometimes for diagnostic purposes, to rule out whether or not there's evidence of an ovarian cancer with a cyst, with a sac that's filled with fluid, then we want to make sure at least we can biopsy that or remove it entirely, especially if it started to produce pain. How does this produce pain? Very simple. It is attached to the fallopian tube. During sexual activity, with the movement in the vagina itself, it moves the entire uterus, it moves the entire ligaments. If the ligaments are, the ovaries are attached to the ligaments or the fallopian tube, it will cause pelvic pain. And sometimes you ask the patient, where is the pain that occurs? And sometimes they will tell you the site that it's occurring, and that clues you into where the infection is taking place as well. We also mentioned the case with pelvic adhesions. Pelvic adhesions as a result of inflammation within the uterus that spreads into the fallopian tube can also cause an abscess within the fallopian tube and can actually cause an abscess, a swelling, a hydrosalpinx, and now you have an infertility with a very large, big opening of the fallopian tube here, and that becomes non-functional, but it's a cause of chronic pelvic pain. We also know in the case in which endometriosis, in which we have these deposits of endometrial tissue within the very small to see it, but it's almost like gunpowder-like material that you look into the pelvis with a laparoscope, and you will see these small match head-like areas, which are really at the times of your period, produces bleeding and cause a tremendous amount of pelvic pain. But after producing the bleeding, then when the blood starts to reabsorb, it forms adhesion or these fibrous bands. And imagine your pelvis now being packed with an entire set of fibrous bands. And there's no way you can actually go surgically try and remove them, because every time you do an incision into the abdomen, you exacerbate adhesion formation. And this is the donazole and other medications I use to treat it. But here again, it's a common condition that presents with common pelvic pain. So pelvic pain in our female patients is not only restricted to things like abnormal bleeding, things to do with infection, it also has things to do with common gynecological problems that could go wrong. The same ovary that produces a normal ovum can also produce a cyst. The same normal periods we have from the endometrial cavity, that we have the restricted presence of the endometrium to the uterus. If that's outside it and we develop endometriosis, we can get extreme pelvic pain. Vaginal discharges, if not treated properly, can also result in sequelae in terms of complications like things like pelvic inflammatory diseases. My role here was to describe some of the common conditions that I see in family practice, and most of my friends who practice gynecology full-time that describe them to me, is that you will understand that when you go to your physician and you describe your symptoms, you describe them with a forcefulness and authority that only you as a patient can say, and not apologize for the fact as to why you're there. As recently as yesterday, I saw a very good friend of mine, an 84-year-old gentleman, a very friendly person, very affable individual, who presented with a PSA level of 19. It was unfortunate for this gentleman because basically I suspect that this is a diagnosis of prostatic cancer. However, there was an evidence of infection within the prostate, and obviously it's going to be treated. The PSA level will be repeated, but definitely he's going to need a prostate biopsy. When we think of some of the common concerns that the elderly male patient presents with, it has to do a lot of the times with the prostate and the urethra and the bladder. It's always something to do with, doctor, I'm not able to pass the urine as freely I was able to do before. I'm having difficulty in urination. Sometimes I'm standing at the toilet and waiting for minutes before the passage of urine. At the minute I start to pass the urine stream will just stop and diminishes, and I just have to wait for sporadic episodes of passage of urination. I'd also have the patient who is post-prostatic surgery coming to say, well, there's no evidence of erection any longer, but in addition to that, I'm unable to hold the urine any longer. I have to be always in the bathroom, or else if I don't get there fast enough, I will find that I passed urine myself. It's sometimes unfortunate the way we describe the symptoms, but sometimes there's not much you can do. But let's look at the anatomy of the prostate and try and put into perspective some of the symptoms of frequent urination to sporadic urination, or dysuria, difficulty in passing urine. In addition, that's sometimes retrograde ejaculation, or sometimes even the passage of blood within the semen itself. If you look at the anatomy of the male prostate, this is the urinary bladder. This is the area where the ureter that drains the kidney, that empties into the bladder. The urine then sits in the bladder as a storage organ until that capacity of close to 400 to 500 cc is satisfied in a younger individual. But as we get older, the capacity for holding urine becomes much smaller. Under the influence of cerebral control, that's why we're able to wait until we go to the bathroom to pass urine. This sphincter then relaxes, the bladder contracts, and the urine is pushed through the prostatic urethra and then into the penis, and we're allowed to pass urine through the relaxation of the membranous urethra. So all of this is under the control of the brain itself. But when the normal instances is during the case of the young individual, the vas deferens, the semen that's produced by the testis itself, travels up into the ductus deferens and empty into and stored into the seminal vesicles, but then empty into the prostate itself. So during the course of ejaculation, the prostate empties, the urine doesn't, but the prostate. And sometimes when we do surgery, sometimes we destroy the anatomy, and a lot of the patients, and it's not uncommon for the patient post-prostate surgery to come to the doctor and say, I've got a bloody discharge within my semen. Also, you can find with the younger patients that sometimes present with a bloody seminal discharge. So these are not things that are associated with cancer. These are a lot of times associated with infection that affects the anatomy of the prostatic urethra. And here we face with issues. If you understand the anatomy, it doesn't mean the semblance of blood makes you worry. It also, in addition to that, the passage of urine. Sometimes I hear patients describe, doctor, when I pass my urine, I see thready materials in it. I see possible evidence that looks like semen. I see evidence that looks like blood. What I want you to realize that once you understand the anatomy of the bladder, the membranous urethra, the prostatic urethra, you can understand a lot of what the problems could be, and understand that not everything you need to worry. You need to be seen by a doctor and explain to them what is going on, but at the same time not to worry. Also, what I want you to realize as well is when you know the anatomy of the prostate, when you go for your prostate surgery, a lot of times I find the patients come back to the doctor, I never knew this was going to happen to me. If I knew this was going to happen, I would have acted to have, instead of a total prostatectomy or removal of the core of the prostate, I'll probably have a radiation implant where the symptoms come on are never going to come on. That again is a fallacy. After you've had radiation implant into the prostate, you are going to develop impotence. The issue of that, sometimes you can develop the urinary incontinence, but probably much later and much slower. Would you develop the bloody passage of the bloody urination that you commonly have after TURP or transurethral prostatectomy? Obviously not. But you have to be able to understand the whole concept of what the urinary bladder is, the prostate itself, in order to understand the symptoms of when you pass urine, your ability to control your urine, your ability to describe what you see in your urine. For instance, a couple of days ago, a male patient of mine said, Doctor, I'm passing what looks like stool in my urine. And obviously it was incorrect, because if he was passing stool in his urine, it meant that there was a connection between his gastrointestinal tract and his urinary bladder. Obviously, he would not be sitting in front of me doing that. He'll be lying septic on a bed with evidence of a fistula that's forming there. What he was right about, there was the difference of a discharge coming from the urine that was not normal, but it was altered blood that looks like these thin threads that he described as stool. It is important for us as patients to describe what we see without trying to figure out what it is, because it's a physician's role to actually be able to say this is abnormal, as opposed to saying it is abnormal. This is the difference with motor vehicle accidents, with whiplash injury can result in